Welcome to Section 12 of the Renal Physiology Review. In Section 12, we will go into more detail on the regulation of volume, specifically the regulation of sodium reabsorption, with special emphasis on the activity of the renin-angiotensin-aldosterone axis. Welcome to Section 12 of the Renal Physiology Review. In Section 12, we will talk about the regulation of body volume, with again focus on the renin-angiotensin-aldosterone system. Once again, recall that agents that promote sodium retention tend to increase water reabsorption and increase total body volume. Also, agents that promote sodium retention also tend to be vasoconstrictors, and vice versa. The examples are angiotensin II and the catecholamines of the sympathetic nervous system, that is, norepinephrine and epinephrine. Agents that inhibit sodium retention tend to be vasodilatory and also decrease sodium and water reabsorption. The example is atrial natriuretic peptide. We've talked before about the concept of effective circulating volume. Just to review, effective circulating volume is a portion of the extracellular fluid that is in the vascular space that is effectively perfusing target organs. These target organs are the kidney, the carotid sinus, as well as the central nervous system. The effective circulating volume, rather than total plasma volume, is what governs either the increase of salt and water reabsorption or the increase of salt and water excretion. Most of the times, effective circulating volume and plasma volume are one and the same. However, in certain disease states, such as congestive heart failure, decompensated liver disease, effective circulating volume and plasma volume are not necessarily the same. Effective circulating volume is perceived by the arterial stretch receptors present on the organs mentioned, the kidney, the carotid sinus, and the aortic arch. These stretch receptors are activated by increased blood pressure. They send signals to the brain to decrease sympathetic outflow. The decreased sympathetic tone leads to a reflexive decreased heart rate and peripheral vasodilatation to essentially decrease effective circulating volume. Once again, it is extremely important to remember that decreased effective circulating volume does not always equal decreased extracellular fluid volume. Decreased effective circulating volume can be seen with decreased extracellular fluid volume. This is in the setting primarily of true volume depletion, the hallmark example being severe hemorrhage. However, decreased effective circulating volume could also be seen with normal extracellular fluid volume. Sepsis, where vasomotor tone is deranged rather than total body fluid, reflects a scenario when effective circulating volume sensed is low, even though extracellular fluid volume is normal. This is simply because decreased vasomotor tone leads to decreased sensation of stretch by the receptors in the aortic arch, in the carotid sinus, and in the kidney itself. Increased extracellular fluid volume and decreased effective circulating volume exist in three states known as the great edematous states: congestive heart failure, decompensated liver disease or cirrhosis, specifically cirrhosis with ascites, and nephrotic syndrome, where plasma oncotic pressure is extremely low and thus effective circulating volume is low as well. However, all three of these states are states of increased extracellular fluid volume and states where sodium and water is actively reabsorbed even though extracellular fluid volume is increased. The central mechanism governing the regulation of volume is the renin-angiotensin-aldosterone system. Just to review, the release of renin is stimulated by low renal blood flow sensed by the juxtaglomerular apparatus. Any fall in effective circulating volume will be sensed as low renal blood flow by the JGA. The JGA will then release renin. Renin cleaves the inactive enzyme angiotensinogen into angiotensin I. Angiotensin I then is converted to the active form angiotensin II by angiotensin converting enzyme. Angiotensin angiotensin-converting enzyme, or ACE, has created angiotensin II, the active hormone. Angiotensin II has effects on the brain to stimulate ADH release via the pituitary gland, on the adrenal gland to stimulate aldosterone release, and on the kidney itself, promoting efferent arterial vasoconstriction, as well as increased sodium reabsorption in the proximal tubule. The end result of increased activity of the renin-angiotensin-aldosterone system is to preserve effective circulating volume by increasing sodium reabsorption and increasing water reabsorption, thus inducing a state of positive volume balance. The control of the sodium reabsorption via the renin-angiotensin-aldosterone system is governed primarily by the release of renin. Once again, the stimuli for renin release are decreased afferent arteriolar stretch, sensing decreased circulating blood volume, norepinephrine, which is released by the renal sympathetic nerves, which innervate the juxtaglomerular apparatus, also decreased tubular chloride concentration sensed by the macula densa. All of these suggest GFR has fallen, and thus glomerular capillary hydrostatic pressure is low, which the kidney interprets that effective circulating volume and total body volume is low. Renin then catalyzes the conversion of angiotensinogen to angiotensin I. Angiotensin I is converted to angiotensin II by ACE. ACE is found in the endothelial cells of the lungs as well as in the kidney itself. Important to remember is that the concentration of ACE is much higher in the kidney than anywhere else. Just to review, the juxtaglomerular apparatus lies adjacent to the afferent arteriole. It is a specialized collection of cells that sense renal blood flow that then stimulate renin release. It also linked to the macula densa, which senses chloride delivery, which also may suggest changes or falls in GFR. With regard to the control of sodium reabsorption, angiotensin II directly stimulates sodium reabsorption in the proximal tubule, as well as stimulating aldosterone release from the adrenal cortex. Also important to remember is that angiotensin II is a very potent vasoconstrictor, and it constricts the efferent arterioles preferentially over the afferent arterioles. It does this to maintain GFR in the setting of vasoconstriction and decrease effective circulating volume. Its vasoconstrictive effect on the systemic circulation increases blood pressure. The angiotensin II effect on the adrenal gland leads to the release of aldosterone. Aldosterone, as we mentioned before, increases sodium reabsorption in the collecting duct through the epithelial sodium channel. The increased sodium reabsorption leads to increased potassium and hydrogen secretion by the principal cells and the intercalated cells of the collecting tubules. Let's review again the effect of aldosterone on the cortical collecting duct. Recall that there are two types of cells in the cortical collecting duct. The cell on the top is known as the principal cell. The cell on the bottom is known as the intercalated cell. The collecting duct is the primary site of aldosterone activity in the kidney and is an important site of the final regulation of sodium reabsorption in the nephron. Increased aldosterone activity stimulates both the synthesis and the activity of this epithelial sodium channel. Sodium is increasingly reabsorbed due to the aldosterone activity, and potassium and hydrogen losses increase. Aldosterone excess syndromes can thus be reflected clinically by sodium retention, which leads to volume overload and hypertension, potassium loss, manifested by low serum concentrations of potassium or hypokalemia, and increased hydrogen loss, which is reflected by increased serum concentrations of bicarbonate or metabolic alkalosis. Let's go over the response to decrease effective circulating volume. A decrease of effective circulating volume leads to increased sympathetic tone, including increased activity of the renal sympathetic nerves. There's decreased stretch of the afferent arteriole, Renal blood flow falls, GFR falls, thus there is decreased chloride delivery to the macula densa. All of these factors, the decreased tone, the decreased afferent arterial tone, the decreased renal blood flow, stimulate renin release. Renin release then will lead to increased activity of angiotensin II, which leads to increased aldosterone activity, as well as vasoconstriction both in the renal and extrarenal circulation. The end result of that is increased sodium retention both in the proximal as well as in the cortical tubule. The increased blood pressure helps to increase effective circulating volume that is sensed. An increase in sympathetic tone also leads to an increase of cardiac contractility as well as heart rate, which leads to increased cardiac output and blood pressure. Constriction of the venous system moves blood back into the arterial circulation, increasing venous return as well as increasing cardiac output and blood pressure. What about the opposite? What is the response to increased effective circulating volume? Essentially, all of the opposite things that we saw with decreased effective circulating volume occur. Increased ECV leads to decreased sympathetic tone, decreased activity of the renal sympathetic nerves, increased stretch of the afferent arterial, renal blood flow increases, GFR increases, and there's increased chloride delivery to the macula densa. These will all inhibit renin release. This leads to decreased angiotensin II activity, less vasoconstriction, and less sodium reabsorption. Also, sympathetic tone falling leads to decreased cardiac contractility and heart rate and decrease in cardiac output. There is more vasodilatation, blood pressure falls, there's more venodilatation, there's more venous pooling, and a decrease in cardiac preload. This is all an attempt to decrease effective circulating volume to maintain this parameter in a fixed range. One of the other responses to increased effective circulating volume is the release of atrial natriuretic peptide. Atrial natriuretic peptide is released due to increased atrial pressure or stretch. When cardiac preload increases, atrial size increases, and stretch receptors sense this increase in volume. The increase in atrial volume stimulates the release of atrial natriuretic peptide. These are synthesized and released from the cardiac cells in the left and right atria. This actually increases GFR and increases the filter load of sodium by dilating the afferent arteriole and constricting the efferent arteriole. It also decreases sodium reabsorption in the collecting tubule. It promotes sodium excretion by inhibiting renin release. There is increased arteriolar tone, so there is decreased renin release and decreased angiotensin II activity. It also directly inhibits aldosterone release and inhibits the release of ADH, so there's decreased water reabsorption. All these, in summary, serve to decrease effective circulating volume, increase sodium and water excretion.
This concludes Section 12 of the Renal Physiology Review. The key points to remember from Section 12 are that the kidney is primarily responsible for the regulation of volume. It does this by the regulation of sodium balance. This, in turn, is facilitated by changes in the activity of the renin-angiotensin-aldosterone axis.